quit smoking obviously had the best outcomes. All right, so what can you do in terms of counseling women who smoke or use substances during pregnancy? How many of you are familiar with the 5 A's model? Quite a few of you. Okay. What I want to do is just walk through the 5 A's. This is the model that ACOG has recommended. That is the best practice for working with women who use substances during pregnancy. It was originally developed for smoking, but it can be adapted to any substance. Because I've been doing smoking, you're going to hear me talk mostly about smoking, but this model will work with any substance. It's a brief behavioral intervention that has been found to be pretty effective. And you can do it quickly, 5 to 15 minutes. And I know 15 minutes might not be quick if you're a busy obstetrician, but that's the beauty of this is that you can involve all of your office staff. You know, your front office people, your nurses, whoever it is, can all be part of this process. All right, so here are the 5 A's. Asking about tobacco use, so obviously the first step, and I'll go through these in more detail, is asking every woman who comes in about tobacco or drug use. Oftentimes people will shy away. I've been surprised that some people, I don't want to offend people. I don't want to ask them, you know, are you using drugs? As a healthcare provider, it's part of their health. It's related to their health. It's necessary to ask. Universal screening, even better if you're doing drug screening in practice. Okay, second step is to advise women to quit. Kind of goes without saying, but I'll give you some numbers in a minute. You'll be surprised. Next, to assess their willingness to quit. You can't really help until you know how willing they are to quit. And then assisting them with their quit attempt and arranging for follow-up. The 4 and 5. All right, so how do we ask women about smoking or substance use? Okay, those of you who work with pregnant women, do you always ask? Yes? No? How do you ask? What do you ask? What's the question you ask? Mostly what I hear is that women are asked, do you smoke? Okay, simple, straightforward, saves on time, right? About half of women who smoke are going to say no to that question. Okay, that is a question where there is no option to admit that you're smoking that is in any way socially desirable. It's a yes or no question. Okay, we can increase disclosure rates substantially if we frame it as a multiple choice question, where they have an option to pick that doesn't make them look so bad as, yeah, I smoke and I've been smoking at this same rate ever since I got pregnant. Okay, if you give them an option, well, I've cut down, okay, that's a positive thing, or I stopped after I got pregnant, they're much more likely to disclose when you have this range of choices for them. Okay, so you ask a woman and she answers one of the first 3. Very important that you affirm that choice, reinforce that that was a good thing, especially for the women in the 3rd group. Those are the ones you need to keep on because relapse, 50% or more of women are going to relapse before they deliver. So it's important to keep those women in mind as well. But the top 2 groups are obviously the ones that if they tell you that they're smoking still and have cut down or continuing to smoke or use any substance, again, that's where you move into the advise step. Now here you can see that this question can be adapted for secondhand smoke. We use it for secondhand smoke, or you could put any substance in here, whatever it is. And you may have to give them examples, you know, asking women. I was amazed one time when I walked into a practice and found out that the question that was being used was, do you use any illegal drugs? You know, no is going to be the first question out of most people's mouths. The word illegal is a little bit inflammatory, so it's important how you ask the question, to think very carefully about how you're answering it so that you get the best disclosure possible. And these 5 steps, but again, when you're dealing with illegal drugs, obviously it gets even a little more complicated. These are the alternate questions. If you've seen the ACOG form, there's just a little tobacco, yes or no, and then amount. We have, in some of the practices where we have worked, actually put the sticker right on the ACOG form so that you have the multiple response choices for both smoking and secondhand smoke, and then asking them about how much and how long they've smoked, because that's important for intervention. We actually had a stamp made where we could actually put this on the chart. So whatever form you use that's asking about smoking, even if the form itself can't be modified, you can always attach something to it so that you can make sure that you're asking in the best way possible. All right, so after you ask, you've identified women who are smoking, who have maybe cut down but are still smoking, or recently quit. So the next thing you need to do is advise them to quit smoking, and this needs to be a clear, strong, personalized message. So something like this. As your healthcare provider, my best advice for you and your baby is for you to quit smoking and reduce your secondhand smoke exposure. I need you to know that quitting is one of the most important things you can do to protect your baby and improve your own health. Okay, that is very clear, positive, but clear. You would be surprised at how many women where the providers say, yeah, I told her she needs to quit smoking, walk away and claim that their provider did not advise them to quit smoking because of what they heard, what they wanted to hear, and what the provider may have said. Okay, so a provider says something like, you need to give up cigarettes. Okay, that might not necessarily be interpreted as you have to quit. Okay, so you need to be careful about what you say and make sure that it's very, very clear. Okay? It's also important to personalize it. So talk about the impact of smoking on the baby, the family, the patient's well-being. Anything you know might be important to that patient is good to bring in to this advice to quit smoking. All right, next step is to assess. You can't really work with women to help them quit smoking or using any substance unless you find out how willing they are to quit. Okay, so something like this tends to be very effective. So give them a 10-point scale. How willing are you to quit smoking in the next 30 days? Put an endpoint, because a lot of people will tell you in the abstract, oh, absolutely, I want to quit smoking. Maybe next year, okay? We have a really important window of opportunity when women are pregnant, and so we want to narrow that field down and talk about a time frame, 30 days, maybe 2 weeks. You may want to bring it down, especially if this is someone who entered prenatal care late. You might want to even bring that down more. So asking them on a scale of 0 to 10. So what you can then do is follow up with, what would it take to make you more willing to quit? In other words, move, say, 3 points on the scale. So they can really start thinking about some of the issues that affect their choice to smoke or their choice not to quit. Okay? And this will allow you to move into assisting them. Okay, so you get the idea. So if you would move, say a woman says she's a 3. Okay, well, what would it take to get you to a 6? What would have to happen in your life? Okay, well, I'd need my husband to quit smoking, or I'd need, I'd need an assurance that this will be better for my baby, or whatever it is, and that kind of gives you a point of personalization that you can move into assisting. All right, so if a patient responds they would like to try to quit within the next 30 days, obviously you move on to the assist step. What if somebody's a 0? I am not at all willing to quit. Nothing will move me off my 0 point. There's nothing there. Okay, so that's the point where you really need to move into an educational mode. Talk to them about the dangers, not in a sense of, this is going to be horrible for your baby, you're a horrible person, not that sort of message, but a positive message where you could really improve your baby's health if you could quit. What do you think would happen if, and give scenarios, whatever it is. So sometimes women are at 0 because they don't have the information that they need. They don't have the education. So sometimes just increasing their knowledge of the dangers will help move them off that point. Others may be very fearful of withdrawal or different things. So this is the point where you can find out what some of those things might be. All right, the assist step, and this is usually what takes the longest if you're going to do this effectively. Some of the initial considerations, you have to be very aware of the addictive nature of nicotine. Physical addiction, obviously, withdrawal symptoms, if anyone here has tried to quit knows how absolutely awful that experience can be. But there's also a behavioral addiction component. There are certain triggers in the environment that are going to lead a woman to want to smoke. And whatever that is. So start talking to them about what are some of your triggers, what are some of the things that really make you feel like you have to have a cigarette beyond just that withdrawal. So, every time you get in the car, or after you eat, whatever it is, and to start looking at some of those things. And we have to address both of those components for successful cessation. Also important to recognize your own biases about smoking during pregnancy. As I said, you want to be careful not to pass judgment on women and alienate them. You're absolutely horrible for smoking or using drugs during pregnancy is certainly not the message that you want to convey. But sometimes the bias can go in the other direction. And when I've been out in some of the rural health departments, I've found that a lot of the health department staff themselves smoke. And so how do you deal with that in the context of an intervention? Most people who are healthcare professionals that smoke know that they shouldn't be smoking. And so it's fairly easy to move from the point of do what I say, not what I do. But a lot of times women will call you on it. If you live in a small community, they may very well know that you smoke. They can smell it on you, whatever it is. And so you have to be very careful that you come across as caring and recognize that this is hard. I had one of my staff who was a very recent quitter when I hired her, really was able to use that message with women. I've been through this, I know how hard it is to quit, and so sometimes it can work to your advantage, but you do have to be careful that they don't see what you're doing and take that as an okay to do it. All right, so asking open-ended questions. This is really the key as you start to assist women. So talking to them, first of all, about the role that smoking plays in their lives. Most women who smoke will tell you, or use any substance for that matter, that plays it is a positive force in her life. Even though there's negative health consequences and everything else, maybe it's socialization. She goes and takes a smoke break with other people. It's a stress reliever. It's something to do out of boredom. Whatever it is, you have to recognize that there's been a long time where that substance has played a key role in her life, and looking at what that is and how that might be changed. Okay, so moving into discussing motivations for quitting or continuing. Okay, so what is your motivation to quit? During pregnancy, there's one key motivation that we can always bring in terms of concern for the baby and the baby's health and development. But there could be other motivations too. So talking about what those might be for a woman. Talking about past attempts to quit. Most smokers have tried to quit at least once. And so talking to them about how that went for them. You were able to quit for 6 hours. How'd you do it? 6 hours doesn't sound like much. It's a big deal for somebody who smokes a pack a day. Okay, so when you went 6 hours without a cigarette, how did that work for you? What were the things that got you to that point? And then what were the things that led you to have the cigarette at the 6 hour mark? Okay, so working through those past attempts, so maybe next time you could quit for longer. Okay, talking obviously about the health benefits and personalizing those, it being important for your baby to be healthy. Think about what that would mean if your child didn't have to go to the pediatrician every other week and, would do well in school and all of those things. And the cost savings. This is a big one out in our rural communities where a lot of women suffer from a lot of financial issues. If you are a pack-a-day smoker, you spend more than $2,000 a year on cigarettes. Okay? That's huge for women at some of these income levels. And so talking about how much money you can save is often a real eye-opener. Take that money, put it aside, save it for the baby, save it for something important to you. And oftentimes that can be a motivating factor. All right, identifying the triggers and the roadblocks. As I mentioned before, talking to women about what is it, under what circumstances do you really feel a need to smoke? Is it when you're around this person? Is it when you're in this situation? Is it when you're feeling this way? And talk about other things she can do instead. Okay, it may be for a while she needs to stay away from smokers, really limit her contact with smokers. Maybe she has some non-smoking friends and she can go hang out with those people for a bit. Or go to places where smoking isn't permitted, if the smoke is really bothering her while she's trying to quit. So look at ways to deal with the stress, exercise, relaxation, whatever it is, finding ways and helping her to recognize it's going to be difficult. But at the time when she's really craving a cigarette, if she has a whole list of things she can do instead, and those are thought about ahead of time, those can go a long way to help getting past that craving at that point. Withdrawal symptoms, it'll obviously occur, the physical withdrawal, how to deal with them. A lot of women are concerned about gaining weight, eating a lot, whatever it is. So talking about how to deal with the cravings and the need to put something in your mouth. But one thing that I have found that's been very effective with women is to let them know that if they are experiencing a craving, withdrawal symptoms, and they can get past that, it will pass, whether or not they smoke. In 30 minutes or so, they'll be on the other side of that. And so helping them to recognize that and see what they can do to get past that. All right, some other things you can do in terms of assisting is helping arrange social support, whether it be there in your practice, in your health department, wherever you are, or helping them line up social support, tell them to tell everybody they know that they're quitting so that they have a lot of support and a lot of resources. Getting a quit buddy, finding different ways to get that social support that they need. Another thing we found very effective is to have them set a quit date. and sign a contract. Okay? Obviously, this isn't binding, but it holds them to the idea that I've decided to do this, and I'm going to make an effort. We do this with women and tell them to take it home and put it on the refrigerator, and so that it's right there, it's in their face, they've made a commitment. But it's also important, too, when they fail, and let them know they may fail, that's okay. We'll do another one. Okay, so you do another one and you put another date on it. But sometimes just that is the thing that will get them past that craving. Providing self-help materials. There's a lot of materials out there related to pregnancy smoking. And you can personalize these depending on what a woman is, what's important to her, whether it's the health effects on the fetus, whether it's other people smoking around her, all of these different things to give her the self-help materials that are most useful for her. And obviously we have an excellent quit line. It's always good to send women to the quit line. And I have heard, I haven't called myself to find out, that they will personalize quitting for pregnant women if a woman calls in and lets them know that she's pregnant. All right. Other things in terms of the self-help materials, these are kind of some areas that you can maybe target: the health benefits, how quickly women can see health benefits, dealing with cravings and having coping skills, different ways to manage stress, quitting without gaining weight, dealing with other people smoking around you, preparing to quit. One thing might seem obvious, but not always. When a woman's quit, tell her to get all tobacco products out of her house. Okay, if they're not there, if she has to get in the car and go to the store to go get them, it puts her maybe a little bit further out from going back to smoking. Had one woman who said the only time she smoked was when she was in her car and she kept her cigarettes in her glove box. Okay, I said, could you maybe put them in your trunk instead? Okay, so it meant she had to stop. She had to take that extra step in order to get that cigarette. Anything you can do to separate them a little bit, because when that craving hits, it's hard to really work through that temptation. So making it harder to go back to smoking. Okay, so keeping your hands and mouth busy. This can't be underestimated. They are so used to that hand to mouth. Anything you can do to keep the hands busy, keep the mouth busy, whatever it is. And then issue about gaining weight. Obviously, pregnancy is a little bit more of an ideal time not to have to worry about that. But we don't want women to gain too much weight either. So, keeping a food diary, staying busy, lots of water, the typical things we tell people in terms of managing weight. All right, dealing with other people smoking around you. Okay, asking people not to smoke when they are around you, and if they do, leave the environment. A lot of the women we work with really don't have control of their home situations. They live with other people, they live with mom, they live with grandma, they live with in-laws, and they smoke. And they really are not empowered in their environment to tell other people not to smoke around them. So helping them find ways to minimize their smoke exposure. Can you create at least a smoke-free zone? Can the room where you are most of the time be smoke-free? Can you make sure nobody smokes in the car with you in a confined area? Like I said, go to places where smoking's not allowed, surrounding yourself with non-smoking people. This is hard. This is one of the hardest things for women to manage. All right, one thing you may hear when dealing with women who smoke: well, my mom smoked with me when she was pregnant with me and I'm okay, or I smoked with my first child, second child, and that child turned out okay. This is a hard one. This is a really hard one to deal with. And so there's a lot of things you need to make them aware of, that each pregnancy is different. Things will have different effects. It depends on your overall health, your nutrition, your stress. All of these things kind of go together to have the effect, have smoking have an effect. Older women are more susceptible to having smoke-exposed babies with problems. So as you get older, the risks increase. The amount of secondhand smoke in your environment. So it's really important to make them recognize that, well, it's not an absolute for everyone. You're increasing the chance of problems. You're decreasing your child's potential, every time you keep smoking at whatever level that is. All right, pharmacologic intervention. Behavioral intervention obviously is the first line treatment for smoking or any substance. We do use pharmacotherapy sometimes for very heavy smokers who are unable to quit on their own. We have very limited data, though, on the safety of most of these things in pregnancy. About the only trial that's been done that has been shown to be safe is the nicotine gum. So if you have a woman who wants an aid, the nicotine gum is the safest. Just make sure that she's truly reducing her smoking while she's using it, because otherwise you're increasing, and that's why I put this here. We have a man covered in nicotine patches. What you do is obviously you're increasing the amount of nicotine. We give these to women in the hospital, and then they go out in the parking lot and smoke. So you have to be really careful that the intervention you're giving is not actually increasing the nicotine exposure for the baby. And obviously with other substances, for example, women who are using heroin and some other substances, we need to medically manage, and they may use methadone or Suboxone with pregnant women. But that obviously needs to be very closely managed. All right, so finally our last A is arranging. After you have given women tools that they might be able to use, then arranging for follow-up to monitor their progress. Don't just send them out there and never talk to them again. When they come back in, make sure you bring it up, you talk to them about it, make sure they have someone that they can call, whether it's the quit line, whether it's the clinic where you're working. Ask them about concerns or difficulties, be willing to help, and be positive. You know, even if they come back and they say, I tried, I really tried, encourage the fact that they tried. Okay, or encourage the fact that they went 3 hours without a cigarette, or they went one Saturday night without going out and drinking. Help to build on their successes. And as I said, the Quit Line is a very good resource for women who are smoking. All right, so encourage them to be smoke-free, drug-free, but counsel them to quit down if that's the first step they're willing to take. Praise any attempt. And if you can acknowledge how difficult behavior change can be. I think this is one of the things that we underestimate when we work with people. If you are just sympathetic and say, I know how hard this is and I know how hard you're trying, that can go a long way for a woman who might not have a lot of other support in her life and may really help her connect with you and be willing to listen to the message that you have for her. All right, so here's an example just real quickly as we finish up. Say that you have a patient who reports that she smokes a pack a day. She's tried to quit twice. Okay? In one attempt, she was able to remain smoke-free for 32 hours, so over a day. She reports that she might consider quitting now and that she is pregnant, now that she's pregnant, but she doesn't really think she can. So how could you assist her? Okay? What are some of the things you could take from this scenario or maybe ask her about? And I know we're short on time, so I won't take a whole lot of input on this, but just to give you an idea here, some of the things you could do. Really build on that success of the 32 hours and use that. Okay, what worked during that 32 hours? Maybe she tells you that, oh, during that 32 hours, I didn't go to work. I stayed home from work because people go on smoke breaks and I just can't handle that. Okay, I took this step. Okay, obviously she can't stay home from work every day probably until she quits smoking. Okay, so then talk about, okay, so what are the triggers at work? How can you manage those? Are there people who don't smoke? Someone you could do something with? Could you take a walk? Could you, sit and work on something for the baby? Whatever it is. Okay, what do you enjoy doing that might help during the next quit attempt? So what could you do in place of some of those behaviors? So the key really in all this, hopefully you've gotten, is that you need to personalize the advice, drawing from what the patient tells you. So no 5A's intervention looks the same with any two patients is the key. You really need to draw from what they're telling you. You need to listen to what they say and then turn that back to them. So reframe what they tell you, very important thing when you're trying to do behavioral interventions. Whatever they tell you, repeat it back to them. Okay, now I want to make sure I understand. I understand that you're very worried about the health effects on your baby, but you don't think you can quit. Okay, so how do you think we can come together to find a way so that you can have both of the things that you want? Okay, so really framing it for them. All right, last thing here, suggestions for post-delivery assistance. Unfortunately, about 50% of women who quit smoking or using drugs during pregnancy resume within 6 weeks after delivery. Okay, so now we have a baby in an environment where there are drugs and cigarettes and alcohol. Okay, so if she was able to quit once, okay, she could do it again, or perhaps even work with her so that we don't relapse. Okay, so you can use the 5A's at any point during pregnancy and after pregnancy. It's important to encourage them to remain quit, continue cutting down, talk about the health benefits, the financial savings, whatever it will be. And one key thing I do want to mention is that breastfeeding is not contraindicated for smokers or for some drug users. In Northeast Tennessee in particular, we find that the number one reason why women don't breastfeed is because they're smoking. Okay? American Academy of Pediatrics has said very definitively that breastfeeding is not contraindicated for smokers. So you have a baby who's already at risk because of the prenatal smoke exposure, the postnatal smoke exposure, you're putting them at even further risk if they don't breastfeed. So the benefits of the milk far outweigh the harms of the small amount that they're going to get through the breast milk. And you can talk to women about safe breastfeeding practices. So, smoke right after you breastfeed, go outside, wear something that you can take off. There's a lot of different things you can do to minimize the baby's smoke exposure. Social drinkers, also okay. One thing that you can encourage women to do is if they're using, not to breastfeed right after, and if they've used at a level they're concerned about, to pump and discard that milk, okay, and use an alternate feeding for the baby at that point, but not to discontinue breastfeeding completely, okay? Now, there are a few exceptions. Women who are using marijuana, heroin, cocaine, or meth should not breastfeed. And the American Academy of Pediatrics has said about these in particular are dangerous. Now, it's not universal. If they're social users of marijuana, you can kind of get around this, but they shouldn't be while they're using these substances breastfeeding.